I am. Okay. Where's Abby? Can you hear me now? Can anyone hear me? Am I talking?
I can hear you now.
Okay, good. So it's just Abby. Good. Cool. I'll move through. Dude, first. All right.
My mute.
We're gonna make it easy. 44-year-old female presents right lateral elbow pain. Haven't seen her. She's still in the waiting room. What's your first thing you think of?
Did you see me, Dave?
I did. I gave you the easy one.
Let's go with that tendinopathy.
Damn, there you go. Off the board. Ariel, what do you think? Second most likely.
Radiculopathy. I don't know if it's second most likely, but something I'm gonna clear.
It's okay. It's like Family Feud. You want to get something on the board and not get a strike. Abby, you're up next on my list. Another differential immediately enters your mind.
I hate being put on the spot, Dave. You know this.
Yeah, Abby's in the subway right now, if you can't tell.
What?
And the background noise.
Oh, sorry.
You're good.
Right lateral elbow pain. Fracture.
Okay, we can put it in there. Right, she's still alive. You haven't got a strike yet in the Family Feud. The person who's registering his iPhone. There's an iPhone in here. So there's somebody here on their iPhone.
That's me, probably.
All right, iPhone.
Sorry, I'm a hot mess.
No, it's good. You're allowed to be a hot mess. What else? First, it comes in your mind. This list populates of what are the potential things this could be. You have tendon, nerve, bone.
Muscle strain.
I would put that as a differentiation. Is that Ariel chiming in to help you out?
Oh yeah, sorry. I thought you were just asking everyone.
No, it's okay. You can chime in and help out. It stinks to be a hot mess hanging out there and then not come up with this, which is normally obvious to us all. Next one, John, what you got for me, buddy?
Yeah, maybe like an arthrosis or an arthritis, depending on how acute it is.
Good. That was such a good answer. I'm going to pick on Teresa next, just because I feel a lot of passive aggression to her after my experiences in Chicago.
Now, to be honest, I jumped on late and didn't hear the case. So
Okay, 43-year-old female present right elbow pain. This is like the Family Feud. The top 6 answers are off the board.
Okay, I thought maybe I was missing more details. Did we say radiculopathy coming from proximal cervical spine?
Yes, for those of you who can read, that would be number 2.
Oh, okay. It would help if I pulled this up. Let's go with something in the thoracic spine, dislocated rib.
Dislocated rib causing right lateral elbow pain.
Yeah, why not?
fine, I'll put it in. You can make an argument for that. All right, what else? Do we have anything else?
How about radial nerve entrapment, Dave?
Yes, that'd be peripheral. So I'll differentiate that from radiculopathy. We'll put that up in there. We'll put that as a different. It's kind of nerve, but yeah, it's more peripheral versus we'll call radiculopathy more of a central kind of. Anything else? Any other major structures we're missing in this area?
Maybe something ligamentous, Dave,
Yeah.
like a radial.
Ligamentous. Mine is something happens like that. It operates actually in this way. I could have tendon, muscle. I could have referred from neurological fracture, muscle strain, arthritis. And then there's the like the ones that I put at the back of this list where you go back like the fracture, that rib dislocation. Those other things down there are things that are referring downward from a distance. So like if I were to make this list in order of likelihood, they may drop down, but they would still be in the back of my mind on the differential list, even though I may immediately like that Bayesian model weight them as being like 5%. Like I'm not going to give them much consideration unless the evidence comes to this 43-year-old female presents with right lateral elbow pain after a fall on the tennis court. Well, now all of a sudden fracture may move up the list. Possibly a ligamentous thing. I fell on my wrist and I have lateral elbow pain. Then ligamentous injury at the elbow is going to move up my list. All these things would be potentially on the list for this individual. We know we see the most of. And then there's those other ones. So what we want to do with our questioning as we get to this case is figure out, okay, how can I come down to the true most likely? Arthritis, in there, we can probably put it there, but we'll put articular dysfunction. Pop it in there right there. Good. What would with John, we'll go ligament. What would the ligament injury, what would the history sound like? What would you expect to hear? And what would your assessment look like? This was, say, a woman and this is a ligamentous injury. What does the rest of her story sound like?
Well, I suppose it could kind of go both ways. I mean, if she's like a tennis player of some sort and she has some type of overuse injury, I would say probably something insidious that started happening over time as she continued to play. She probably would be tender, it would be localized. It wouldn't have a ton of referral. I would expect it to be pretty much in one spot. And I would stress that ligament and see if that reproduces the pain. You could certainly palpate over it as well. I suppose if it was more acute, like what you were talking about, like she fell and hurt it, maybe some more swelling, probably more flared up. If it, depending on when it happened, if it happened a couple of days ago, it probably would be, a little bit more painful than if it had happened a while ago. And I would still stress that ligament and palpate over it and see what I can find.
Yeah, looks like you're going to look for probably trauma with ligament. It could be a chronic breakdown, which you may see, but they tend to happen slowly without really a clear pain pattern until something else starts to occur, like instability tend to drive it. So if we're looking at a ligament chain trauma. Now with an elbow that if you've ever seen any elbows, you fall on the elbow, but what's probably more common is a fall on the outstretched hand. And that energy gets transmitted through the radius where you'll dislocate the radial head or traumatize the ligamentous structure that restrains it, is what I'll see. So I've seen those where come in and they're banged up in their wrist. It's a bad wrist injury, but you come to find out that they've strained the restraining ligamentous structures in the lateral elbow. You don't often see lateral. I have not seen lateral ligament injuries. Has anyone seen a lateral collateral ligament injury in the elbow? Other than a radial, or has anyone seen the annular or the radial ligament strain?
I don't think I've ever seen a ligament strain in the elbow ever, to be honest, unless I missed it, which could be, but I've never seen one.
Yeah.
I've given
Go ahead.
myself a UCL injury.
Mhm.
My hand got stuck cross country skiing with a pole. I went back.
Yeah, it's a good mechanism for it. Trauma. You'll see problems with them in, people who pitched or played baseball a lot when they were younger will have, lax and unstable UCLs. And then what you'll find out later on in life, they're coming in for something medial condylitis, elbow condylitis, they'll have something going on. And you'll find that you'll bump into the fact that they've had this lax ligament for a while, and then something is breaking down. And so I'll bump into it. So I will look for ligamentous stability in individuals, but oftentimes they may have they're coming in for medial condylitis or something else related. And then you bump in like, oh, they have an elbow instability, and that ligamentous instability is now creating X to happen, or an articular problem because the elbow is unstable. So ligamentous, I would initially think maybe history of trauma, any falls, any recent change in patterns, any kind of newer change in activity. As you said, it's going to be, palpation. It's going to give you probably the most information on that individual. Good. We looked at my list. We've not picked on Chris. We haven't picked on you yet. Pick a number, Chris. Not 1 through 10. I'm going to pick a hard one.
I was gonna say number 1.
Oh, good choice. You're a wise man. What is this woman's history?
Again, if it's like lateral epicondylitis, more like repetitive use injury, lot of like gripping type tasks. Probably just gradually onset, got worse over time.
What if she's played tennis 3 times a week for 10 years? Comes in with right lateral elbow pain. Would that explain her elbow pain?
Unless there's something different. She changed something with her routine or had a certain way she turned wrong.
Yeah, that's exactly right. Is that if the repetitive activity that they're very used to, their bodies have time to habituate to, then I don't necessarily expect to see it. If I get that history where I'd say we'll make her a tennis player and she's had an onset, then I know partly what I may need to do there is to start digging in to see, okay, can I find something to explain a change in pattern? She changed tennis coach. Did she change, racket or grip? She now all of a sudden she started doing common one to see. She started doing CrossFit, and she's playing tennis. So now, okay, she's doing barbell lifting, which overloads the elbow extensors, and then she's doing repetitive activity with it. In the springtime, it's like gardening. So with the tendinopathy like this, I'm looking for somebody who has a pattern of activity. Do I see a change in activity, which will do it? The hardest one sometimes is thoracic, lumbar, lower extremity injury in the shoulder and elbow, because those individuals will develop tennis elbow or shoulder problems because if they're playing tennis or a sport, golf, for instance, then they're not rotating the lower body properly, so they make up for it with the upper body. So if I'm seeing something where they do something where the arm is the extension of the body in activity, then I need to understand, am I generating enough force and momentum through the hip, lower quarter, lumbothoracic region? That's where TL junction comes in this one. She could be essentially somebody who has a TL junction issue or thoracic issue that now manifests as tendinopathy due to the fact that she is trying to compensate with her elbow and wrist instead of getting a rotation. So repetitive use. What else would we find in this individual? What would be the 2 tests you would do to kind of make yourself feel pretty confident that you have tennis elbow?
Check the resisted wrist extension, and then palpate right over the lateral epicondyle.
Where would they be sore?
Sometimes can radiate from the area, but usually right directly on the tendon, common extensor tendon.
But know what I see? Your humerocondylar ridge over radial head. It's not uncommon where it kind of blends with the radial head capsule. That can be deceiving because then now you need to determine whether, okay, is it most common one is an extensor tendinopathy, but you can have a radial ulnar or radial humeral dysfunction. line in as well. So it could be articular dysfunction over radial. And little distal. That's all kind of, it's not usually this far down, but I'll call it muscular. Muscle tendon. Many times you'll find these people with different palpation points. Some people be very tight insertional tendinopathy right along the humeral condyle. Over the radial head, very common spot to see it. And again, a little further down, you'll sometimes in that musculotendinous region further down in the elbow. So you can kind of have these different ones. And, I don't know if it always holds true, but, an area where there's a little more blood supply, maybe the lower one might have a little bit better healing time and potential. Higher ones tend to linger. When you do have that pain that's insertional along the condylar ridge, many times those people, when they get better, they feel good, and then they bang their arm into a wall. And for a short period of time, it all comes back and it's terrible because it remains latently sensitive for palpation. So you can kind of, see it kind of branch along these different regions there. So your palpation zone, will be kind of in those areas. Anything here we're missing? Anything else you would see in this person who has repetitive, tendinopathy in this individual? Anyone can chime in, discussion board, verbalize it.
You talking functional loss or objective loss? I mean, they would have.
Yeah, what you might see in the
Difficult
findings, like what
to-
does this person tend to have that would solidify your thought process? Yeah, this is definitely tendinopathy. Are we missing any tests, or is there something else? The other question would be, what else may contribute to a tendinopathy in this individual that's not obvious?
Was it the gripping test?
Dave, we could look more globally at hip function, thoracic rotation, maybe if they're missing some mobility or even just power
Wait a-
generation from the ground up.
Yeah, absolutely. But think about being way down the line. That's something that you're definitely going to do. That's going to be definitely a contributor. If she's a tennis player or a sports athlete, definitely going to be contributing to it. But that's kind of down the line. First, what this is about doing is what we're going to do is develop our differential and our bias correction differential. And like when we start to look at the hip and even in the thoracic spine, what we're getting into there is etiologies. Like what are the potential causes of this that contributed to it? But first, what we're going to do is we're going to form is, okay, we've got our differential diagnosis. I've got my diagnosis. And if this is a tendinopathy case, in this case, then all the rest of this 2 through 9 become bias correction. I'm confident in my diagnosis because when I look at my history, okay, I can palpate it, it's painful. Range of motion, gripping is painful. That's not common in radiculopathy. Cervical range of motion, neural tension tests are negative. Radiculopathy, my Bayesian model drops way down low as a possibility. And what we're doing is going through right now is their differential. So what I would put where you're talking about, Kevin, is etiologies, and we're going to do that. But right now we're going to focus on the differential diagnosis portion of it. Like what new grads do, and stuff because they want to jump and do what they see me do is they'll go right from, okay, I got tendinopathy, and then go right to the hip, like in the first few minutes of their evaluation. And it's like, they haven't gone through 2 through 7 or 2 through 9 adequately yet. They need to sort through that in their mind first to make sure, okay, I'm good with this. So I agree, Kevin, but we're gonna stick with the differential first, and then probably in future sessions we'll jump into those etiologies.
Sure.
What else could cause, again, latent things back in my mind, not front thought in these individuals. Other things that cause tendinopathy, medication like Cipro. Do I have something funky where it's just multiple tendinopathies like Eric talked about? That may be just something in my line of questioning my bias correction. It's like, okay, I don't see a clear pattern. She didn't play tennis. She wasn't doing anything. Somewhere in there, as I go through this, I'm strengthening my tendinopathy. She has a tendinopathy. I'm still looking at my etiology. So I don't see a clear change in pattern. Something happened. She's now crossfitting where she did it before. Then, that may be something down the line I need to consider. All right, Stephanie, how you?
I'm doing well. How are you? So you cut out at the last little bit. Am I doing number 2 or just kind of going
Working the distal muscles.
down any of them?
Oh, a second, my microphone changed. Can you hear me?
Yes.
Hold on. My sound is out. Okay. You hear me okay?
Yes, I can.
You can hear me. I can't hear you. All right. Give me 1 second and I'll fix. All right. Somebody say something so I can see if my microphone is working again.
I can still hear you.
Oh, good. Yeah, I got a pair of like earbuds and it occasionally just jumps on and takes over whatever I'm on. So that's kind of what happened to me. So I apologize for that. Right over it. Good. Radiculopathy. What do we have? What questions? What tests?
She might have well, questions I would ask, kind of like how long it's been going on for, what is the quality of the pain, and then like where on the elbow she feels it, kind of if it's localized or if it's kind of on the whole length of the forearm or the upper arm for that matter as well. And then movements it bothers her with.
Probably gets into maybe if you're talking with Jim, saying it's an idea that what questions differentiate this from another one. So quality of pain is certainly one. Paresthesias, if it's lancinating, radicular symptoms, those all stand out as neurological. So quality is that, location helps, right? Because if it's diffuse, it's, that's going to tell you that, okay, well, I can spread well beyond what I would expect from the local area of a local tennis elbow. And though you can get sensitization of the surrounding structures, it's usually not a significantly large area of expanded sensitivity zone. It can be along the lateral elbow, but it's not going down to the movements. What movements would you consider to be provocative?
Wrist extension, flexion, maybe. Potentially movements of the neck as well.
Yeah, with that one, it's in a wrist, we say wrist movement, what you're going to think about it there is it more of a neural tensioning position versus like if I move the wrist, is okay, am I looking at for extensor, tone? So is that what you're more talking about? Because if I do, wrist extension and it's painful, would you expect that to be painful with a radiculopathy?
I guess no. So it'd be more neck movement then.
Yeah, so you that way, it's not so much that the testing, that's your differentiation test. You go in here and this is tennis elbow. I do my extension test and my palpation test, and they're kind of equivocal or negative. Then I have to start to kind of think, okay, let me move to my second hypothesis. In this case, radiculopathy. What would you do? So be palpated, resistance test was negative. What's the next thing you would do? Thinking it's radiculopathy.
Could go on to the upper limb neural tension testing. Could go through cervical range of motion, compression, distraction.
Compression, distraction, nice and easy, quick to do. May use that real quick in there. If I want to take a quick dirty look at it, eventually I'm going to know that, okay, I got some type of restriction there. So what I know here, if I'm thinking going this route and getting these positives, I am thinking C6 region. I am thinking, okay, oncovertebral joint, how's the facet joint move? Have I lost the lateral glide? Am I stuck? Am I in a, is the superior segment stuck in maybe extension or inframedial glide? Something that would close off that foramen, potentially. Do I have something there? You can have an osteophyte filling it, but if it's more mechanical, early onset, 43 years old, hopefully we have a restriction there. you know, eventually we can get into. That's kind of why I had to put in something in the rib dislocation. Go was because, yeah, I could have something in the thoracic spine stuck in flexion, is driving C6 into extension. Because I'm flexed down lower, so I extend up higher, and that could be causing a radiculopathy. Even though that would probably be more like what Kevin was talking about, that rib or that thoracic, would more be an etiology or a cause of the C6 segmental dysfunction than an actual, like the actual pathology. So that'd be the more likely scenario we'd see. Radiculopathy, we know, quality of pain, radicular neuropathic pain, location of pain, diffuse, is it matching a dermatome? You know, do I have negative, palpation and resistance testing? So I can kind of rule out then the musculoskeletal structure and start to relieve. Okay, do I have a radiculopathy? Hang on. Okay, fracture. What does a fracture look like? Jacob, you're the next name I saw. Let's go with a fracture.
Fracture is going to be very painful. You're going to have some swelling, probably some bruising as well. Traumatic mechanism of injury, unless it's obviously like a stress fracture in the lower extremity, but elbow related, probably more traumatic.
Yeah. Yeah, painful history of trauma. Swelling can be hard. It could be swollen. It may not be swollen because basically the elbow can absorb a lot of fluid in there to kind of see what's going on. So very painful trauma, probably tender to palpation along the bone. But the history there will kind of tell you that you don't expect a spontaneous fracture in this location. Fracture in some ways it's kind of easy. So that fell and I have elbow pain kind of, dramatically changes what we start to think of, because we know that, okay, fracture is one of them. Maybe ligament is strained if the radial head, was dislocated and relocated. Could be it. We could be looking at articular dysfunction, traumatic arthritis, muscle strain. So with the fall, we know it kind of morphs what my bias is and how I'm going to check this. But fracture may be where I start out. That'd be, okay, here's the worst possible case. Does this feel like a fracture? Or if I feel comfortable that, okay, this is less likely a fracture, I'm looking at something that may be more of a muscle or traumatic tendinopathy or articular dysfunction, and then move into that route. So that's what I say. As that person comes in, like even that 39-year-old female in a state paper with right lateral elbow pain, those next pieces of information in our mind start to we automatically weight these different differentials. And again, the idea of Jim will talk about where I'm missing one, or I don't often think of the radial nerve entrapment, or I don't, I've kind of forgot about checking the ligaments. That becomes that form of availability bias where, okay, there's a bias I have because I'm going to have to pick one of these other diagnoses because I'm unaware of one of the ones that could potentially be it. And that's where if you miss something where it was a ligamentic strain, but boy, I haven't checked ligaments since I was in school, so I don't do that. So that's where you would miss that on availability bias. That's why these lists in your mind are very helpful to work from. Muscle strain. What would the muscle strain history look like in this individual? Kristen.
They probably have some history, maybe not like super traumatic, but they might have like overused a muscle, like playing a sport or falling, subjective wise. Objective wise, it'll probably be tender to palpation over, it depends on which muscle, but probably over those extensor muscles if it's lateral elbow. They'll have pain with resisted testing, probably some lack of range of motion. Maybe some flexion restrictions.
What's the pain resisted testing with like I said, acute muscle strain look different than a tendonitis or tendinosis?
Would it like break quicker, like more of a breaking weakness with a strain versus a tendinosis?
Yeah, I mean, you certainly have breaking weakness because there's pain inhibition going on. So it's going to show off. So what would a tendinosis look like?
Just like pain where like over the common extensor tendon.
Yeah, but if they
I don't know.
Yeah, but they have a chronic tendinosis. They tend to be less irritable. chronic tendinosis cases, you tend to either have to load it in a very lengthened position or with a moderate to heavy amount of stress to elicit the pain. Usually it's not quite as irritable. Your muscle strains, I expect to have, pain inhibition, paired force generation, acute soreness and history of strain. Tendinopathy, like acute tendinitis, will have kind of similar features. It's going to be very painful to resistance. You may be able to resist. It may be breaking, really depending on where you are in that tendinitis cycle. Because that's partly what one differentials here would be that idea of tendinopathy. And then there's subcategories. Do I have an acute tendinitis, or am I dealing with a case of tendinosis, more of this chronic irritation thing? So it's good to have in your mind a mental map of, okay, what is the difference when I kind of do these tests? Yeah, I had pain, but when did that pain come on? Did I have to fully lengthen the muscle? Did I have to go to basically a 5 out of 5, resistance, and then they notice the irritation over the radial head? Or it's like, okay, boy, I just pushed down on the wrist and they got severe pain over the extensor muscle mass. So it's good in your mind to start thinking about, as we look at these differentials in tendinopathy, to frame out tendinitis with the acuity of it versus tendinosis, which is a little bit more chronic in how it presents in my specialty. And muscle strain, it's going to be more indicative of the acute tendinitis looks like, as far as pain inhibition, reflex inhibition. Again, the location probably a little different because you're not looking at the tendon, you may be looking at muscle belly. Example would be mid-muscle strain in the hamstring versus proximal hamstring tendinosis. Ooh. Arthritis. I think a meeting with him. Violetta, talk to me. What do we have for arthrosis?
I would say like pain behavior wise, that kind of stiffness in the morning, as well as with inactivity, probably relief with more activity to a certain point. Possible swelling in the joint.
Talk about a little bit. Let's say it was severe enough. What would you see in the range of motion?
Limited range of motion.
Yeah. Which one is kind of more limited in the classic pattern of restriction?
Oh, for the elbow
Yeah.
joint.
Mhm.
Extension.
Yeah. Extension is more noticeable, because of the olecranon not being able to kind of grow into the fossa. But the classic capsular pattern is, I think, is flexion more limited than extension, because it's a much larger excursion. So you get to about here and it kind of stops. It feels like it's a much larger range. Where you get the elbow here and it stops here. So I think the range of motion loss is greater, but sometimes in flexion when you look at the capsular patterns. But you notice it much more in extension. It's much more obvious.
So it doesn't follow the capsular pattern, is what you're saying?
No, I think the capsular pattern is flexion more limited than extension, but capsular patterns are also debatable. There are up to 4 different capsular patterns that have been described for the hip. So when you have 4 different capsular patterns that could potentially be out there, you find that everyone can be a variation of them. So it's good to understand capsular patterns, use them, you find them, tells you, okay, yeah, I got some tightness here. This is probably accounting for the arthrosis. But that's what I would look for.
Okay.
So just nice to know, somebody asked you, I think flexion is the classic tighter pattern, but you always see extension. Extension just stands out more. Because how often people don't walk around like this all the time, but it's normal to see an elbow out straight.
Am I off the hook?
I don't know, what do you think? You got anything else? Does anyone have any hard questions for her?
Anyone can add, but not a question, maybe.
No, questions would be great. All right, I'm going to throw this one. Michelle, describe your mental picture of an articular dysfunction.
As far as subjective goes, I would I would ask them like what activities they do that cause the pain. When do they notice the pain? Is it episodic? I would probably go right into quadrant testing. Based on that, I would check joint glides and get your end feel. That will drive kind of your treatment.
That pattern isn't similar from what we looked at in the cervical and the lumbar spine, or even the thoracic spine. You know, she's looking for episodic in nature. She's basically using a quadrant test, which is like a screening test to see, okay, do I bump into a limitation? And from there, she goes into a more specific test. Okay, let me check my joint glides and end feels. Where I am, have I lost an end feel? What are the different, and you can just list them off, Michelle, what are the different end feels, the different articular restrictions you would likely see lateral elbow pain in your mind, you know, from most likely to least likely? And there's no actual list, so whatever you say, I'm not gonna argue with.
I would say maybe like radial ulnar. Could be radial humeral, could be ulnar humeral, or no, I already said. I would probably say maybe radial ulnar is most common. It's like an abducted ulna.
Yeah. That's an almost a very common one I'll see.
And as far as like the actual end feel, you're like pathomechanical versus capsular versus hypermobility.
And a radiohumeral dysfunction isn't one of those things you may see here where the joint gets irritated, it's being loaded in some way. You know, you're looking at there where I can have articular dysfunction. That'll be the harder one to distinguish, is that radial ulnar or radiohumeral articular dysfunction versus the tendinopathy. So once you get the tendinopathy, that's where even if I find some tendinopathy, I'm going to come in, and part of my bias correction is I'm going to do the biomechanical assessment for the articular dysfunction. Right, one category. That's part of my bias correction, but I also want to know, is one of these things contributing to it? This could be a contributor to the tendinopathy, or this could be a cause of the pain. So I want to get a sense of, okay, what's going on with the elbow? What's the lay of the land? Is what I need to know. So, you know, doing that articular dysfunction one, it's part of my bias correction, but it gives me information because, hey, I got a tendinopathy, but hey, I have an abducted ulna. That now is like Kevin talked about the hip. That's the driver of this one. Kevin, if you're out there, radial nerve entrapment, big guy.
I look mid-humerus, kind of the triceps. That radial nerve dives deep about right there. It's a bit of a stretch, but you could have someone maybe eliciting, you could reproduce symptoms with just deep palpation compressing that area and see if it reproduces it, or maybe some resisted elbow extension where you're working that triceps repetitively and see if maybe the thought of it compressing down that nerve, if it reproduces it there after multiple efforts. Those are things that I would look at, but that would pretty much be after I ruled out a tendinopathy of, you know, they're not painful with gripping or wrist extension, then I might be looking at that stuff, but it's definitely not my first go-to.
Yeah, let's say it was radial nerve entrapment. What would you expect the classic case of that to look like? If it was like textbook, what does this person look like?
Depends how long it's been going on, but you might see atrophy of the common extensors. Let's see what else. Really pathologic. I think trying to think of hand postures, maybe radial nerves.
It's a little more low grade. It's a little more low grade than that. I think it's that subtle one we're trying to get away from. It almost comes in that category where they talk about, if they ever talk about segmental facilitation or axoplasmic flow at all, if you haven't talked about that, where you're getting this low grade neural compression, it atrophies the muscles and the neuromuscular junction and creates kind of tendinopathies. We haven't gone into that yet.
have some atrophy, it would be a red flag for sure, or something supportive.
Does that,
More of
does,
it
is there any
evidence for that.
sensory component in this nerve?
There is. I think there's a radial recurrent nerve. It comes out of a little pouch, and I think comes pretty close to the lateral elbow there. There's that recurrent sensory nerve there.
Mm-hmm.
We could do some sensation testing maybe at that level to
I would look
tease
for
that out.
sensory. Yeah, look for sensory nerves. It's funny, and there used to be there was a format. It changed names since, but there used to be a group. You know, it was a guy named Ma who talked about biomedical acupuncture was their thing. It was really just one of the early dry needling programs. And you know what they did is they used a kind of a Chinese, you know, basically modified acupoint model of what are the hottest nerve points in the body. And one of them was the deep radial nerve point, which is kind of that spot right in there. You can press on the deep radial nerve between the extensor tendons. Being that most people have a little hot spot. If you poke there, most people are hypersensitive right in that location. And that's a kind of a common spot of irritation. And it kind of holds true. And what they looked at there was as you poke down that nerve along the course of those muscles, the more sensitive it was as you progressed further, the more irritated the nervous system was. They used that one. And the second hottest one was like a sural point. It's on the inside of the tibial bone, really just kind of under the pes anserine, along the medial border of the tibia, and there's a tender spot there is the second hottest spot. So they would do a mapping thing of neural sensitivity there. It has to do with this is probably very little, but it's kind of an interesting thing is as you palpate along there, you're thinking deep radial nerve. You can also kind of come along the upper elbow, and that can be a neural tension point that can be described in there. More commonly, I'm thinking it's more of a tendinopathy. But yeah, I would look for it's a nerve. Does it have a anatomical dermatome? Do I see dermatomal changes? Do I see force output in any muscle that would be distal to the compression that we would have? That's what we nothing really fancy in any one of these. The idea is that to work through a differential, because everyone's always wondering too, it's sometimes, oh God, what would an oral practical be like? It would be pretty much like this. You know, it's an idea that in your mind, you can start to frame out, okay, how does a tendinopathy look different than a radiculopathy? And you can do it fast and almost in your peripheral vision so that you're already kind of processing this information without actively, you know, thinking about it and going through your list. And then at times, sometimes where I feel like, okay, I don't have a good handle on what's going on with this individual, then I come back and I work my list. My differential now becomes, okay, I'm going to do a full exam, but I'm comparing all this data to these different differentials. And I will work through it from a differential diagnosis standpoint as much as I can to say, okay, you know, it doesn't match tendinopathy, but what do I have? Does it match radiculopathy? You know, where can I go in there? Okay, no, you know, is it articular dysfunction? So being able to work through this list kind of really helps frame what you're doing. It really helps also prevent from those blind moments where all of a sudden it's like, man, I don't know what's going on and I don't know what to do next. We all have them. You know, if you don't have them, let me know and I'll make sure you have one by the time Eric finishes with you. But these are nice to kind of be able to frame it in those moments, but also kind of work through these things. You know, the next phase of that would be looking at, you know, differentials. That's where we got into a little bit. That's why I didn't do rib here. We're gonna get rib, we got hip. Dysfunctions, we'll get into this, we'll do differentials. You know, again, of course, yeah, we're gonna spend a lot of time on the articular dysfunctions, but it's really important to know that we're really looking at when you have the articular dysfunction, that it can most commonly, it can create a tendinopathy. A neural compression that's low grade up in the neck or a cervical degenerative thing that irritates a nerve and changes neural output can create a tendinopathy or a ligamentous laxity because a lack of control of the system that's peripheral to it. So those things will come into play. Teresa, you gave me a rib dysfunction. Explain to me the rib dysfunction and how that is impacting the elbow.
Well, Dave, I
I've just been thinking about how this program has opened up my eyes to look at other areas of the body that I wouldn't previously have even thought to assess. So really, I think where I was going with that was more like a segmental dysfunction somewhere in the thoracic spine. I'm not stalling. You asked me for an opinion and I gave it to you, okay? It's down on the list, but it's something.
I had to put it in there, as much as I wanted to beat you up, and I couldn't, and it dismays me.
I'm here to take it. It's
Mhm.
okay.
If we have this, and we'll call it rib, but even then, if you think about it, just rib or it's called thoracic. So, you saw this from Clellens and some of the patterns like 10 years ago. They're saying, hey, you don't need to manipulate the cervical spine. You just need to manipulate the thoracic spine, and you'll fix your cervical issues. And then kind of comes full circle, and 6 years later, like, yeah, okay, our research wasn't as good as we initially thought it was. You probably still need to treat a bit more in the cervical spine. Is where it came out of there. Some of the early work they were saying is that, hey, just manipulate for safety the thoracic spine. You don't need to do cervical. That was coming up. So, these things ebb and flow, but it did come back there. So, Teresa, how would a C, and let's say a T2 flexion subluxation cause a radiculopathy, or radiculopathy that would give me this elbow pain?
We're
Indirectly.
talking of flexion,
Indirect.
subluxation on that
Flexion subluxation.
ipsilateral side.
Yeah, it's called
On
anterior
the
translation.
ipsilateral side.
Yeah.
Flexion subluxation. So I have trouble with extension. I have trouble with right side bending.
Think about what that segment does to the segments above it. What would that flexion subluxation cause maybe in the few segments above it? What would the segments above it do?
They would be hypomobile compensating.
What position would they be in, likely? And feel free to bail her out on the chat part, or let her twist you in.
Extension relative to that segment.
Yeah. If that segment is being forced into extension, what would likely happen what could it do to the foramen at that C6 level?
Be putting excessive shearing forces.
Yeah. So this person could be somebody who gets intermittent symptoms.
So you're saying my answer wasn't wrong?
I'm not saying that out loud. But it's one of the things you're going to find out, and why when they did the initial clinical picture rules for manipulating the thoracic spine to treat the cervical spine, why it did work is because you could have, let's say, if I'm stuck in a flex position, like kyphotic upper thoracic spine, and you get that cervical compensation, and that can then close off the foramen. Whether you have a extension subluxation at that, let's call it C5, C6 level, can do it, or it could be just being put in that position chronically and creating lateral stenosis on that level. So if that person has normal mobility in the cervical spine, but the restriction is in the thoracic spine, and you treat the thoracic spine, and now all of a sudden they can balance that joint a little bit better and decrease that that extension moment, it can take the pressure off of the nerve. That's that interplay of that thoracic kyphosis being one of the biggest predictors on treating neck pain and some of those lower cervical level problems. Is, okay, what position is my upper thoracic spine in, and how is it contributing to my neck dysfunction? So in the perfect model, they have a subluxation of the thoracic spine, anterior translated, do a traction manip, I clean it up, and lo and behold, I can take away some of their radicular symptoms or referred symptoms. Now, the trickier one is when we talk about if we have, let's say we have an axoplasmic flow issue or a segmental facilitation that's being caused because I have the same rib lesion or the thoracic lesion is anterior translated, and now get this low-grade irritation on the C6 nerve root, where maybe I'm compressing a little bit of the neurotransmitter flow through it, or I'm sensitizing it. So I'm changing the neural output or the nutritional flow to that segment. The nutritional flow issue is that he's sending.
I'm gonna. It's
He's
okay.
sending
Can I come and see? I can come see you in 6 minutes. Okay, you're good.
Okay, we got 6 more minutes. You're good. No,
My
it's
bad.
nutrition through the nerve root. That idea that, okay, if I get decrease or compression through there, axioplasmic flow, nutrition through the nerve gets diminished. Again, neurotransmitter, things the motor end plate can't replenish, it breaks down, I get poor recruitment, I develop tendinopathy. That's the axioplasmic transport model of how a tendinopathy in tissue can break down. You know, I think what we also see is that segmental facilitation, where I get something nociception within C6, or I get irritation at the C6 local level at the cervical spine, and now I get down ramping of the neural output out of that segment. The dimmer switch gets hit. I see this all the time. My triceps, they have a little bit of something going on. They have pain inhibition in their triceps. It's weak but non-fatigable. Mobilize C6, C7, and bam, you know, all of a sudden they have 5 out of 5 strength again. If it was a compressive radiculopathy, it shouldn't recover that fast. So this thoracic rib lesion can set these things up in the cervical spine. So that's where, yeah, I've got a tendinopathy or I've got a radiculopathy in the elbow, or radiculopathy coming from the cervical spine. But at some point, I'm going to want to, in my first visit or my second visit, kind of explore, okay, what's my thoracic spine doing? And what are the chances I can kind of create some benefit for this individual by, hey, there's a thoracic driver in this. I can find that, I get super excited because it gives me something I can do that can potentially decompress the system. So understanding what the thoracic spine is giving me here is important. Yeah, you may find, depending on your flow with the patient what you're doing, you know, where you need to be and how fast you go there. So Grace is not wrong. She's not right, but she's not wrong. Kevin, you explain to me the hip.
You.
Go ahead, revel in it. Kevin's still there. Is he off? Eat a sandwich.
I'm here, Dave. What was the question?
You mentioned the hip. How would a hip, and again, you pick the sport this person plays or thing they're doing. How does their hip cause their tendinopathy in their elbow?
They could be missing rotation at the hip. I would think more force generation. As they plant to put force through that hip, can they transfer appropriately from the ground up? Would be things I'm looking at. So we could isolate it, look at hip abductors, external rotators, and then, you know, look at the other side. Is there a discrepancy right versus left? And then maybe just look at more functional movement patterns. Can I watch them kind of go through a backhand push off and rotate through that upper extremity? You know, what's the quality of motion? Are they transferring load from, I don't know, if it's a right elbow, can they transfer from left to right for a backhand type motion?
Mm-hmm. Okay, this person, they injured their hip 4 months ago. They don't have any pain now. They're good now. What would likely be, what do you think you might see going on there with this individual? Now they develop tennis elbow down the road. Range of motion is normal.
Strength normal as well?
The range of motion is normal.
It might move up to T-spine and see, can they dissociate, or can they couple the hip and the trunk pelvis?
Yeah, let's stick with the hip. Hip's dysfunctional. You can see it when they do things, but something's off with it. But why?
Well, there's all kinds of things we could look at to rule out the hip or rule the hip in. So we could get into specific hip testing and identify, do I have a joint issue here? Do I have a soft tissue issue, or maybe a capsular issue? As you're saying, range of motion's fine. I'm looking at, do they have pain at the hip? And if so, what's driving that?
It's all good. But since we're showing time here, what I'm looking for here is what you often get left with is a dysfunctional pattern that's left over after the injury. they're still gimpy around this. Their nervous system, in the sense that they've had this injury, my hip wasn't right. When I drove and rotated into my hip, I got a spark of pain. Their local map could be off, or the cortical map could be changed. And it's very common in tendinopathies and injuries that eventually our cortical map kind of rewires a little bit, and we change the way we do the motion. We end up using a thoracic strategy, or in this case, we'll say an elbow strategy or shoulder strategy to generate force and momentum with an activity or to do something. And I lever away from my hip, and I don't use my hip. Be with gardening and shoveling, that I don't want to drive through my hip, so I'm going to pull more through my arm. Tennis, obviously, I can swing with my arm without generating body speed or footwork. My footwork is going to be slow, even though I don't have pain and I have normal range of motion, because my motor pattern has adjusted, and I have not readjusted it. So, it's just always nice to kind of think about that too, that in the absence of this, man, I don't find the joint is off. It probably was months ago, and if I had something happening, but now it's not. What I'm stuck with is what's left over. So as I do this, even when I manipulate a hip, harder work is trying to get the pattern to change afterward. That causes subluxation. How do I, does it come from the foot? Do I go from the hip? Is something else driving it? The motor pattern retraining is where that person probably needs to be rehabbed, whether we're seeing it, in this case, an elbow injury, because they're still not moving well through the hip or using the footwork based on their altered pattern strategy. That's where a lot of the rehab comes in. So as I always say, it's like, hopefully what we learn here with the articular works is some of the fastest stuff you'll be able to do. And then harder stuff where you really want to spend your time with is, how do I retrain these motor patterns afterward so that I don't get reoccurrence? Get buy-in. The hardest part is sometimes you relieve their pain and they go on their way. But I encourage you to kind of spend a lot of time on working on these motor patterns and that next phase of what we do. But so it's just nice to kind of take a look at the elbow, model we're going to use and how we're going to look at it. This is the way Jim looks at it, in the videos. He used the elbow as an example very often, but kind of work through this thing. And if you take this and we go to the wrist, we go to the shoulder, we go to the ankle, same model. Ligament, nerve, articular, arthrosis, muscle, fracture. So by the time we get doing this, it'll get boring because you have the system down. And what it does, it gives you a very kind of clean way to kind of move through this in a thought process. Hope it was helpful today. Hope anybody fell asleep. You guys did a nice job with it. Good seeing you again. Any last minute questions before I shut?